Welcome to our next TIRO MDS tumor board this morning. We've got a wonderful tumor board that I'll introduce in just a second of pediatric thyroid cancer cases this morning. So some challenging cases that the adult endocrinologists hear about and get to see them when fortunately most of them grow up and do well. Just a reminder that we do have our Voices of Wisdom podcast for medical professionals each month. They come out every third Tuesday of the month and are sort of nice 10 or 15-minute snippets of educational contents on very interesting topics from experts around the world. Now, our panelists this morning, we've got some new faces on the panelists. I was going to say some old faces, but that's probably not the right way to say it. Never mind. We've got some young people here for the panelists today. I'm Mike Tuttle. I'm one of the endocrinologists at Memorial Sloan Kettering Cancer Center. And we'll go around and I'll skip Andy, but we'll go with Goli. Introduce yourself and tell us who you are.
Hi, good morning, everyone. Thank you for the great opportunity to join you. I have the good fortune of being an endocrinologist, but I also am a pediatric oncologist, so I can bring both worlds together. And certainly thyroid is a big intersecting second malignancy challenges that we see in our survivors of childhood cancer. So I will hopefully be able to share a case on that with the panel.
Fantastic. Jonathan?
I'm Jonathan Wasserman. I'm a pediatric endocrinologist at Sick Kids in Toronto.
Fantastic. Ken?
Ken Kazahaya from Children's Hospital of Philadelphia.
Fantastic. Mary?
I'm Mary Frates. I'm a radiologist at Brigham and Women's Hospital in Boston with a particular subspecialty of ultrasound.
And Bill?
I'm Bill Faquin. I'm a head and neck surgical pathologist and cytopathologist at Mass General Hospital in Boston.
And Steve?
Good morning, everyone. I'm Stephen Waguespack. I'm an oncologic endocrinologist seeing both kids and adults with thyroid cancer at MD Anderson in Houston.
Fantastic. And Ka?
Hi, I'm Ka Kit Wong. I'm a nuclear medicine physician at University of Michigan.
Fantastic. And last but not least, Dr. Bauer, while we bring up the cases.
Excellent. I'm Andy Bauer. I'm a pediatric endocrinologist at Children's Hospital of Philadelphia and fortunate to know everyone on the panel. So thank you for everyone agreeing and for this opportunity. My goal is to say the least and let the panel say the most. All right, so we have 3 cases we're trying to make it through. So if we don't have full discussions for all 3, that is still, I think, of interest to try to make it through all 3. So the first one is a young patient of ours. These are all recent patients, a 4-year-old whose parents noticed a lump in her neck in the spring of last year. The primary care provider ordered labs and an ultrasound, which revealed the findings that you can see here and on the next slide.
Mary, give me a quick look right there. Go back one slide.
That was quick. So what we can see on the top left image is that the thyroid gland is massively enlarged, and you can tell that for 2 reasons. One is the same criteria that we use in adults. The isthmus anterior to the trachea is markedly enlarged. We usually see it less than 3 millimeters, and the lateral aspects of the gland are pushing out on top of the carotid on both sides. So we have a massively enlarged gland. And if you look at the lower left, you see the same thing. It's labeled isthmus, but you see that the gland is enlarged. I would not have described this as multiple nodules. It looks like the entire gland is involved with the same process. And particularly on the left side, on that bottom, in the right side of the image, the left lobe of the thyroid, you can see those speckles, those small punctate calcifications scattered through the left lobe, including possibly some macro calcifications. If you switch to the right side of the screen, the top right image shows us multiple enlarged, very abnormal lymph nodes all surrounding the carotid artery there in the right neck. And if you notice, the lymph nodes are enlarged with the same echotexture tissue as you see in the thyroid gland, which is indicative that whatever's in the thyroid has moved out to involve those lymph nodes. And I know there's one panelist in particular who really likes color Doppler of abnormal lymph nodes out in the periphery. And the bottom right image shows us that these lymph nodes are very hypervascular. Now, so if in adults or children, we would use the TIRADS criteria. And so this would be a solid lesion. It's hypoechoic, or you could use isoechoic, but those calcifications, which are worth at least 3 points, 2 more if you consider macrocalcifications in there. We're way at the far end of this patient needs a biopsy. You could throw thyroids out the window and say, based on the lymph nodes alone, this patient needs a biopsy. And we do want to remember that in children in particular, they have a higher frequency of their thyroid cancer presenting as a diffuse process involving much of the gland rather than a discrete 12 millimeter hypoechoic nodule. It can be a different presentation in children's.
Jonathan, I know we're on a thyroid cancer tumor board, and I'm supposed to be thinking thyroid cancer. Should I be thinking anything else in a 4-year-old with this presentation?
Not a whole lot. I mean, sometimes in children with Graves' disease, you'll see a diffusely enlarged gland like this, but this doesn't look like a Graves' gland. Some children with thyroid hormone resistance, if they've been treated for prolonged periods with anti-thyroid drugs, can develop TSH-related hypertrophy, but not with lymph nodes like this. I don't think you're
This.
thinking.
Okay, Andy, keep going.
All right. So an FNA was ordered. This is at an outside hospital. That's the abbreviation OSH. And we don't have the cytology slides, but it was consistent with Bethesda classification 6, so malignant cytology. In addition to the thyroid gland, they also did an FNA of some of the lateral neck lymph nodes, which you can see here in levels 2, 3, and 4, and all were positive as far as having the same cytology. So next slide. So the discussion that was had was what to do next. And because of the size of the thyroid and the infiltrative process and concerns of potential involvement of other structures in the neck, there was a discussion of potentially using neoadjuvant NTRK inhibitor because they had done somatic oncogene testing. And they also had done a CT scan as part of the initial evaluation because of the lateral neck lymph nodes, which was positive for diffuse micronodular pulmonary metastasis, which is about 20–25% of patients that present in this fashion. And here's the CT scan.
I'll just jump in here and say that on those the top 2 left-sided images, you can see that the carotid is lit up with the vertical white stripes, and then along both sides you can see those lymph nodes that are aggressively I don't know if we can say invading, but impacting and indenting and closely adherent, particularly on the right side, on the left side of the image, to the carotid. And you can see that on the transverse images as well. I guess I should point out there's also adenopathy on the left side. They didn't show us that on the ultrasound, but those same abnormal lymph nodes are seen in the lower half of the left neck. So there's bilateral extensive adenopathy.
Okay, and next slide.
Since we're pointing out differences between children and adults, this, thinking of the biopsy, this kid probably had to have it done under general anesthesia or some fairly extensive sedation. He had, I guess, biopsies in 3, 4, and 2, 3, and 4 on each side. So sometimes we have to get away with picking just the most distal compartment and maybe just do 2 or to limit the extent of trauma that the children undergo for the sake of the biopsy.
Gotcha. Steve, and then Goalie, help me. We've talked at these panels before about neoadjuvant therapy in adults and anaplastic and medullary thyroid cancer. Where are you in the, I mean, it certainly is attractive. It's got a NTRK mutation. We can target that. There is a few cases about redifferentiation. Steve, first, what are you sort of thinking about that idea?
Yeah, I think really important. And before I go there, I just also want to point out the importance of using contrast with neck CT. So since Mary highlighted the carotid, that's so critical. And it is not an issue giving IV contrast to anyone with thyroid cancer when you're trying to stage them and work them up for surgery. In terms of neoadjuvant, so it's certainly now that we have more knowledge about what's driving these tumors, preoperative molecular testing, we know that 75% of these kids presenting like this with stage 2 disease are going to have a fusion, either RET or NTRK. And so it does lend itself to considering a neoadjuvant approach before surgery. So we certainly think about it, Mike. What we do here is, we get the cross-sectional CT with contrast, and then we try to ascertain how invasive or not this is locally. We're unlikely to see this in kids, but obviously if there's frank tracheal invasion, or if those central neck lymphadenopathy is just socked in with tons of lymph nodes in that central neck, that would be the situation where we might consider it to improve the surgical morbidity. And but this is now still theoretical, right? There's a trial on selpercatinib with red fusion cancers that the data should be coming out soon. But in children, we need to get more data. But it's certainly a consideration, but I wouldn't say it's a standard approach.
Yeah. And Goli, what's your take on this?
Yeah, so I think I want to step back and actually give you my opinion as a pediatric oncologist. I mean, so for us in the world of pediatric oncology, taking out thyroid cancer, I mean, if you have a targeted lesion or a mutation, that would be our preference. I think the world of neoadjuvant, first do no harm. I mean, we certainly are very grateful to our dedicated surgeons, but I think if you can, render a tumor a lot more resectable without leaving late effects and or challenges, that is our approach. And I think that there are tumors, for example, infantile fibrosarcoma, now that we have the targeted NTRK fusion to that, is just a disease that is essentially sometimes not even necessary for a surgical approach. So I think that's what we predominantly think about. Some people actually, make fun of us as far as how much excitement there is in our world once we see targetable, lesions, just to sort of have a drug. But I think that whole neoadjuvant approach is really the sine qua non of how we think in pediatric oncology.
Can I counter that real quick? Is that okay for me to counter?
Yeah, go ahead, please.
Yeah, because this highlights the difference between pediatric oncology, seeing these patients, and endocrinology, because there is this different thought process, which totally makes sense. But we don't have enough data yet. So we've done this clinically, even with NTRK fusion. We've had a couple of kids, we've done this approach. It doesn't make the tumor go away. It definitely can shrink things, but important, maybe, I don't know if Ken has experience in this, but these tumors can get like this desmoplastic response. And so resection is actually not easy in these cases. It's often a very meticulous dissection because of that treatment response after neoadjuvant therapy. So it's not just so straightforward as I think we'd like it to be.
Yeah, Ken and then Bill. Ken?
Yeah, I would definitely agree with Steven on that. The ones I've had to go in after they've been on like either tumors of other types, even of this type, and they had these targeted therapies, there is a lot of desmoplastic change, a lot of scar tissue. It's kind of really difficult sometimes to get in there and get these things out. So in the kids where we have nice tissue planes and it's very dissectable. If it's not like really invasive of the trachea or the encasement of great vessels and something like that, then I would probably prefer surgery first.
Gotcha. Bill?
Yeah, I think it's very interesting that we know the molecular. Is this something that's done in pediatrics? Because in adult patients, if you have a malignant FNA, you're not going to, most places are not going to do molecular testing right up front on that. They'd wait for the resection. So is it standard to do molecular testing with a malignant FNA in a pediatric patient?
I can step in, but I'm sure there's other opinions. I don't know that it's standard. We have opportunities, especially because I think the primary team was thinking neoadjuvant therapy. So one, there's an opportunity if insurance will pay for it, right? That's the big challenge. But also the Children's Oncology Group has a process now, Project Every Child, where we can send samples for free oncogene testing, typically on surgical specimens. But there are methods, but I think in this case, because the surgeon was wondering if systemic therapy should be used prior, that's why they pursued to get the testing, and were successful in obtaining it.
That's great.
Yeah. Ka, one of the things that would help me was some idea about sort of, do you think this tumor is going to respond to radioactive iodine or not respond? Does the molecular help us? Can you give me any feel for that?
Yeah. So at this point, I would expect it to be iodine avid. And what would be important for this in the presence of lung nodules in the about 4 to 5 millimeter range, which is at the level that radioiodine beta emission would be effective, is really getting completeness of surgery. So when you have a complete resection of the thyroid and the lymph nodes, What that does is it clears the ability of the radioiodine to get to the lungs, which is really where we want it to go. And in children that have very phenotypically predisposition to widespread bulky bilateral lymph nodes, as well as higher rate than adults of going to the lungs, we can get into a situation where there's just a lot of tissue in the central neck, which acts as a sink and stops us from really being effective for the M1 disease in the lungs. So I think that radioiodine would be needed in this case, but really good surgery is important here.
Perfect. All right, Andy, take us on toward the pathology, and let's keep going here.
Yep. So next slide. So thyroid function testing done in a thyroglobulin prior to surgery. You can see here, so mild elevation in the TSH, which we see with infiltrative thyroid cancer in pediatrics, probably the same in adults, and a significantly elevated pre-surgical thyroglobulin, which is just a baseline, not part of the diagnostic workup. No known risk factors and has 2 siblings. Next slide. And so there was a discussion, and that's what we do. We turn to Ken and say, I don't know, Ken, can you do this? It's certainly not my decision. And we did not pursue definitive treatment because Ken thought that this was resectable safely without neoadjuvant therapy. So next slide. So when we get to CHOP, Ken used to do direct visualization. We've now incorporated transcutaneous ultrasound. So there was no evidence of recurrent laryngeal nerve paralysis or paresis. So if you hit play, you can see that. So this is a nice way of, this is point of care ultrasound, but diagnostic radiology can do this as well. And thankfully in kids, it's I think a little bit easier. Ken can comment than sometimes seeing this in adults. So nice midline movement. And next slide. The kids appreciate the ultrasound more than the direct visualization. It's definitely a crowd pleaser.
So did the parents. Yeah.
Yeah. And this was a surgery, so the time it took in total thyroidectomy, central bilateral modified radical neck dissection, autotransplantation of 1 parathyroid. So it seemed to go, and Ken can comment, without significant difficulty in the operating room. Is that fair, Ken?
Yeah, I apologize. I'm on a train in Germany, but so there's a lot of background noise. The surgery actually went very smoothly. I mean, as I said, in kids it's really nice because the tissue planes are usually well preserved, unless even if there's slightly extension from the thyroid or into extranodal extension, they still have very nice neck fascia planes. And it's just a matter of going through it systematically and just getting everything out. But it went relatively straightforward. We use a parathyroid identification instrument, but PTI, and no financial involvement with Medtronic. But it's nice in trying to identify and confirm that you have a parathyroid in the central neck dissection. We did have something that looked like a parathyroid, and was immediately able to confirm that, and then with the PTI, and then sent a piece off to pathology just to double check, and then we implanted that in the CM.
And we use intra-PTH, that's the table at the bottom, to identify patients that would benefit from calcium and calcitriol. It depends on what the level is in the post-operative period. But thankfully, it does not predict permanent hypoparathyroidism. So this patient was started on calcitriol even before they left the OR, is typically our pattern.
Yep.
And thankfully has not had any complications from surgery as far as nerve or parathyroid function. So next slide.
And that helped, like, see the fact that the parathyroid hormone dropped so significantly. I knew that we sort of mucked with the parathyroids, which made me really want to concentrate and really try to identify, did I take one out? And that's what enabled us to identify that parathyroid in the central neck dissection.
That's fantastic. I mean, I'm still stunned that you guys can find them in the midst of all of those lymph nodes in the central neck. I can't imagine in a 4-year-old neck. That's amazing. All right, so what did we take out?
So,
Yeah, go ahead, Bill.
yeah, so this shows on the right-hand side this very impressive involvement of the thyroid by this cancer. This is a low magnification view, and the cancer has a nodular growth pattern which is fairly typical for these kinase fusion thyroid cancers. It's just diffusely involving this lobe. And you can see in this black circle here down at the lower right that the cancer is going, shows extrathyroidal extension, and it's going up to the inked surgical resection margin.
Next slide.
So on the left-hand side, you can see it's sort of a pseudo-papillary growth pattern. It's sort of almost a serous pattern here. It just has a very infiltrative, aggressive look to it. And on the right-hand side, there's a little bit of squamoid differentiation. That's not specific. A lot of papillary carcinomas have that. And in the upper right, you can see the nuclei are looking kind of pale, which is a sign at low magnification that we're probably dealing with a papillary thyroid carcinoma. Of course, we already know that from the molecular information.
Yep. Next, let's give him a high power. Closer up.
And this is great because here you can actually see microscopically the beautiful classic papillary thyroid carcinoma nuclei. They're enlarged, they're pale, and they're overlapping with one another. Just very, very classic for papillary carcinoma.
Next.
And here we have, so, you know, in general, we'd say lymphovascular invasion, but we always separate lymphatic from angio invasion because of the differences for patients in terms of prognosis and potential treatment. And this here on the right shows an area of a blood vessel. So this is angio invasion. You can see the red erythrocytes in there with this big tumor plug. So there's a lot of lymphatic and vascular invasion in this case.
Bill, pause for a second. John, talk to me a little bit about, Bill mentioned that some difference in prognosis or outcomes or whatever between lymphatic and vascular. How do you sort of think about that in kids?
I don't think we have the data, actually. You know, certainly the lymphatic invasion to me is meaningless. We know this kid has lymph nodes involved, so he has by definition lymphatic invasion. There's certainly some evidence from the adult world, and I'm not aware of any in pediatrics, but of a much higher risk of distant metastases when angio invasion is present. And it's something I think we do need to look at in the pediatric context.
And Steve, you cross both worlds. I mean, in the adult land, vascular invasion, if it's extensive, is a big deal. Same in kids or different in kids, or can you tell?
Honestly, I don't pay too much attention to this. Because, yeah, well, in this particular case, we already know this is a stage 2 patient, so all of this is moot.
Right.
If there weren't lung mets, I would already be suspicious of lung mets based on the clinical presentation in the neck. So whether or not angio invasion is called, it doesn't really matter to me because maybe Bill could tell us, but I know it's still, how do you define it? And how closely do they look at this huge tumor sample to find it? So personally, I don't use it so much to make treatment decisions.
Yeah, so angio invasion is very uncommon for these cancers. And so if you hear someone say there's angio invasion, that's unusual, and it implies an aggressive pathology. Also, perineural invasion would kind of go along with that too. I mainly deal with adult patients, and our clinicians do make some decisions and get information from knowing that there's angio invasion, again, that we usually don't see.
But I think part of the difference is
I agree with Stephen a little bit, which I rarely do, but
well,
I think in this case, absolutely. But if this is a patient where the pathology tells me, first of all, if it says lymphovascular invasion, I'll call the pathologist back and ask for clarification. But if there's clear angio invasion, particularly with multiple vessels involved, and the patient hasn't already had their lungs staged, that may change my approach, that may push me more towards imaging the lungs absent other aggressive features that Stephen mentioned. If the neck wasn't as bad, but certainly if there's angio invasion without the other things, I still might be a little bit more forthright about looking at the lungs.
Jonathan, maybe what you're saying too is that it just increases the risk of the tumor. And so your postoperative staging may definitely include radioactive iodine staging, right? I mean, that's
Yeah.
how it pushes us, but I don't think it says you have to give REI because there's
No. It heightens my level of suspicion.
right. It just puts the patient in a different, it would take them to intermediate or high depending on what everything else shows, which still is going to lead to a diagnostic scan, and you'll use that new information to make, treatment decisions. Yeah.
Yes.
Okay, let's show Bill one more slide. Maybe one more. Okay, so go ahead.
Yeah, so this is interesting. It's invading into the parathyroid gland, and that's just another aggressive sign. Here we have another area of it looks like it's angio invasion because there are blood cells in that vessel in the upper left, but I mean, just all around, this looks pathologically very aggressive, and that matches with everything else you're seeing clinically and radiologically.
And one last one. I think you've got a soft tissue that goes along that same theme, right?
Yeah, their soft tissue tumor deposit. That's a new thing that people are talking about when you have these little deposits out in the soft tissue. I think that's a fascinating thing. Pathologists are looking at this for all different types of tumors, and does it mean what is the meaning of that in terms of prognosis, et cetera?
All right, so Andy, I got about 5 more minutes for this case. So
Yep.
take me through maybe up to the radioactive iodine step. So walk us through what
Sure.
happened here.
So this is just the synoptic version, but in text report. So you can see 21 of 65 lymph nodes, no extranodal extension, and then just the details of that. So we don't have to spend too much time on it, but the report matched the imaging
Excellent.
and looked at pathology. And the discussion for the family was we have patients with stage 2 disease with pulmonary metastasis, and the panel can discuss that we're actually not very good at clearing their lung metastasis. So we have 3 prospective studies looking at radioiodine enhancement by using oncogene-specific inhibitory therapy, and the TRAIT trial is one of them. So
Next slide.
next slide. Those are if people are interested, those are the clinicaltrials.gov. Those are the locations of the current participating collaborative sites. And then on the next slide, they enrolled, and so we're starting on larotrectinib. So again, this is a research protocol. We're not putting all patients on this, and radioactive iodine still is effective therapy and safe therapy. So that's the standard approach. But if there is an opportunity and the family's interested, there are ongoing clinical trials that they can get involved in. And so that's the subsequent slide. So these drugs are highly effective. That's not the question. The question is how to incorporate them into clinical practice. So you can see tumor regression, which is shown in these comparative images, CT images, where the micronodular disease almost essentially disappears in many patients. And then the next slide, again, looking at it again and looking at the changes in thyroglobulin, showing that there's regression of the tumor, which is exactly what we want to see. So that's one part of the question for the study. The other part is, does it make radioactive iodine more effective? And that is still under study, under investigation. Next slide. And then here's for Ka Kit.
Yeah. So the child was prepared with hypothyroid, which is very typical for pediatric thyroid cancer, with or without cytomel bridging for this. The TSH is 227 above the 30 that we like, with a thyroglobulin of 30, which decreased even on the larotrectinib treatment, which is what we saw with that response. The iodine 123 scan shows that there's still some regional lymph nodes in the neck, and the lungs don't really show up on the diagnostic scan, but we have to just be aware that whether you do iodine 131 diagnostic or iodine 123, the sensitivity is not going to be as good as a post-therapy scan, which is really your gold standard. So when the radioiodine was administered, in pediatric nuclear medicine, we usually use a activity dose per kilogram. And in this case, it was 2 millicuries per kilogram based on the intent to treat M1 disease. And you can see on the post-therapy scan that we do indeed have targeting of the pulmonary metastasis in a diffuse manner, as well as the residual regional disease in the neck. Again, there's not a lot of disease in the neck after the surgery, which is a really important part of the treatment for the radioiodine. Just because I'm in a mixed adult pediatric practice, I will say that the 32 millicuries that was administered, we would use a weight correction up to a adult body mass of 70 kilograms, which is a very common way we scale down the radioiodine in a child. And I was just doing the calculations. If we were intending 200 millicuries to lung disease, which is a typical empiric dose in adult nuclear medicine for metastatic disease, it will be a 2.8 millicurie dose administered per kilogram. So I really agree with this dose of 100. It would be 140 millicuries equivalent in an adult, if that makes sense. And we know that from all the retrospective studies, we're not going to clear the lungs of disease in the majority of patients. It's going to be like 70% will still have structural disease after 1 or 2 radioiodine treatments. And so getting rid of the lung disease is not really the goal in pediatrics. The goal is to treat the lung disease and get it into an inactive state. And the more radioiodine you do, the less effective it becomes. So in our practice, we will not usually go beyond 2 radioiodine treatments at most. And a child of 4 years is extremely young for thyroid cancer. So I don't think anyone would be very comfortable saying that, oh, I'm giving radioactivity in a 4-year-old. This is, exceptional range of age. In our literature, we're very cautious with giving radioiodine in Graves' disease below age of 5 because of sensitivity of radiation to of tissues to radiation. So in this case, I think that this will be an effective dose, and the child may not need a second dose based on dynamic risk stratification after this.
Good. Jonathan, help me finish this one out. Thoughts about this case or follow-up? What are you thinking here?
Yeah, I think Ka Kit's point is very important. That cure isn't our goal with these patients, at least not currently. Maybe this trial will change that. I do, one thing I would ask Andy in terms of the trial is at this point, once you've administered the radioactive iodine, is this the end of larotrectinib for this child? You saw a really good thyroglobulin response prior to radioactive iodine. If there's structural disease remaining, do you keep going with the larotrectinib or do you pause that? And if so, or if not, how long do you go with the larotrectinib, to which he's clearly responding? I do worry with the increased, with the higher uptake, what are the bystander effects on lung development in a 4-year-old child and radiating a growing alveoli? So I think we need to really balance the priorities of cure of the lung disease with the adverse effects of that much radiation, and there's no good answer.
Yeah, so I'll answer quickly, but the 2 points: one, patients are stopped 5 days after the radioactive iodine as far as systemic therapy and not restarted, and just enter surveillance and back into the same pattern as if they had received radioactive iodine off protocol. So just following imaging every 6 to 12 months and labs to determine if additional therapy is warranted, and if the response is stable. So that's to be determined, right? It's a research protocol. And we think about dose reduction because this enhances radioactive iodine so efficiently. I think that's a really great point and still up for discussion and up for investigation. But we oftentimes give a little less because we worry about, as you mentioned, toxicity of radioactive iodine for all of our patients.
And if I could just bring up a safety point too, is that there is no standard approach to this in terms of when you stop the treatment. And we have no data on safety of combining radioactive iodine with an NTRK inhibitor or a RET inhibitor. And so I know what I've done is I've been more conservative and I stop it before the REI because we don't have that data. Will it cause leukemia 5 years from now? I don't know. So I think we still need to learn. That's why it's like we always have to be cautious in enrolling kids on trials that can help to answer this before everyone starts to take this approach for every patient.
Yeah, Mike, can I actually close from an oncology perspective? Because I know, Stephen, you rebutted and wanted to kind of highlight the difference between oncology and endocrinology's approach. I actually want to use this as an opportunity to invite the adult endocrine approach to change and perhaps to to be a little bit more open to the way pediatric oncologists actually think about cancer in a pediatric host, because I think that there are numerous opportunities, like for example, for us, not every case is a surgical case taking out of the thyroid cancer world. I mean, there's a lot that we put in terms of what is risk defining, risk image defining factors, where a surgeon, no matter how well they can say, I can resect this tumor, if you are a COG surgeon, you will stop and not take that child to an operating room, because I think that there is a way to learn from how you enroll kids on trials and answer questions in a very objective way, rather than, one-offs and two-offs, where then it's going to be very difficult to answer these questions. I think these targeted agents to us provide a whole new realm of how we can think about approaching a pediatric host and, with respect to these extensive diseases, where in some ways you may actually also reduce how much radioactive iodine you actually can deliver eventually down the road. So I think there are many questions to ask, and I think those questions should all be asked in the context of a clinical trial, and it really more highlights why endocrine and oncology need to come together and collaborate in terms of, help advance the field a lot further for these patients.
Absolutely. Well said, Goldie. We couldn't agree with you more. I mean, that's great. That's why you have people that do kids and adult endocrinology. You have people that do endocrinology and oncology, and bring everybody together on a tumor board like this helps not only people listening to us, but also us that are thinking about and seeing these cases. All right, Andy, let's go into case number 2.
All right.
That's a great case. Good
So
discussion.
17-year-old noticed again to have neck swelling, asymptomatic neck swelling, that common theme to all of our patients, adult or pediatrics. By primary care, again, spring of last year, ultrasound was ordered and was referred to endocrinology.
Mary?
Okay, so in this instance, we have on the top left image, we have a pretty isoechoic solid nodule. It's a pretty good size. It's 2.5 centimeters. No echogenic foci. It's smooth. So using TIRODs, again, we'd land somewhere in a TR3. So because if we give it 2 points for being solid and probably 1 point for being isoechoic, hyperechoic. So it's a TIRODS 3. In an adult, you would FNA if it was over 2.5. In the work that we did with applying the ACR TIRODS to pediatric nodules, we felt that the threshold for biopsy should be lower in children than the cutoffs that we use in adults. So this clearly would warrant a fine needle aspiration. The lower image shows that there's some vascularity to the nodule, but it's not a hypervascular nodule by any means. And the transverse view inferior to the nodule, I have to say, I'm not quite sure what you're showing us. It looks like a normal inferior edge on the bottom right of the image. You can see the esophagus, you can see the carotids on both sides. I don't see any low midline or retrosternal adenopathy.
Just trying to show that there's nothing in the other lobe.
There isn't anything to see.
Right.
I didn't see anything.
Showing radiologists normal images. It's trick on the panel. That's good. Next slide.
It's very hard to find things that aren't there.
All right, we stuck a needle into this. Bill, back to you.
Yeah, so beautiful cytology here. This is an abnormal pattern. All of these groups are somewhat crowded with one another. We're not seeing any colloid in the background. So this would fall into follicular neoplasm type of category.
Very good. Next slide.
And this is showing the set. There's some irregularity in the size and shape of the nuclei, but I'm not seeing any overt features of papillary thyroid carcinoma in these nuclei.
Okay, and next slide. What do we got? Just more of the same?
It's more of the same. Yeah, a non-macrofollicular, non-benign pattern. It's a neoplastic pattern.
All right, Andy, and what you guys call this? Yep.
Yep, so it was called as described, follicular neoplasm, and then the question was, what do we do next?
Jonathan, Molecular testing in kids. It's the United States. We love molecular testing in
Yeah,
anything. So
yeah. In Canada, we don't get it paid for, so we learn to live without it. And Bill mentioned this right on the first case. One thing that I wanted to point out is this is, this is Afirma testing. If the gene expression classifiers are not validated in pediatric samples, and so if you do want to do molecular testing in a child to help decision making about going to surgery or not going to surgery, we can't really do a rule out test on a child with great confidence. Certainly the oncogene, the presence of an oncogenic variant would be decisive or definitive. The absence wouldn't be. So we need to make sure that whatever test we're sending for is specifically oncogene testing and not gene expression classifier alone. In a 17-year-old, you may be able to get away with it because I think probably the biology is close enough to an 18-year-old that you can believe the gene expression classifier, but we don't have that knowledge. Having said this, we've got a Dicer 1 variant here. And this is not uncommon in the follicular neoplasms in children. We see them both in benign. I sort of think of this in the class with the RAS variants, it's not really telling me this is a malignancy or not a malignancy. So it doesn't push me any further ahead without knowing the rest of the preoperative staging. I think certainly based on what we've seen, this is a child who I would offer a lobectomy. Can't remember how large the tumor was, but I think a lobectomy would be reasonable. The other point that you've got on the slide is prophylactic central neck dissection, which is certainly a loaded topic. And I'm starting to change my thinking, and this is largely under the influence of Dr. Bauer in terms of the terminology of that approach from prophylactic to non-therapeutic, because I think one of the things that we can gain from a central neck dissection, even if it only done ipsilaterally, is diagnostic and staging criteria. So even if we're not looking to alter the prognosis in a patient with clinically N0 disease, if the pathologic lymph node burden is high, it may change my approach to further treatment in a patient who's undergone lobectomy. So I'd be supportive of offering this child a lobectomy with a non-therapeutic ipsilateral central neck dissection.
Steve Waguespack, this came up in our conference actually yesterday. A Dicer 1, we would routinely get germline testing, right, to see if there's Dicer 1. You don't see it very often, but if it's there, if he was germline, he or she was germline positive for Dicer 1, do you do a lobectomy or do you just do a total thyroidectomy?
We would still just do a lobectomy.
Yeah, that's what we did too, based on probably the same information you have. We're making it up. That seemed to be the right thing to do.
Can I add something to Jonathan's comments?
Yeah, go ahead.
Sorry. So I have no financial relationship with Afirma, okay, but we're working with them to look at this actually in children, and so as a rule out test, the expression classifier does seem to be valid in patients less than age 21. And also now Afirma also includes the oncogene panel if it's indeterminate. So it actually now is also a rule-in test for indeterminate nodules like this one. So I just wanted to clarify that. And then in terms of central neck dissection, we would not, because this all looks like a follicular neoplasm, right, based on ultrasound, and it doesn't look like a classic papillary. So I think we would trust our surgeon to do an inspection of the central compartment, but not necessarily plan to remove lymph nodes in this kind of situation.
Perfect. All right, let's show Bill the surgery. So the patient underwent a lobectomy. Next slide. What are we looking at, Bill?
Yeah, so this is a pretty large nodule. It looks like it's involving a lot of the area here. It's circumscribed by this thick fibrous capsule, and that's something we usually see in carcinomas, is a thick capsule around them. And We can't really see it that well at low magnification. There's a little red arrow in the bottom right, but there are several foci of invasion into the capsule. So this is a circumscribed with so far minimal invasion is what we're seeing.
Okay, next slide.
And so at low magnification on the left and at higher magnification here on the right, we're seeing a diffuse follicular growth pattern without any papillary architecture, which might make us start thinking about papillary carcinoma. But then when you look at the nuclei at high mag, there are no nuclear features of papillary carcinoma. So this, again, we're dealing with a follicular non-papillary lesion here.
All right, and there's some mitotic figures here.
Yes. So we do have I didn't look at this entire case, but they're greater than 4 foci of vascular invasion, and the mitotic rate is huge, much more than I see in almost any tumors in the thyroid. 16 per 2 millimeters squared is very high. Our cutoff with the WHO for calling a differentiated tumor high grade would be 5. So this is a really high mitotic count, and the Ki-67 is not quite as impressive, but it's up to 10%.
Help me here, Steve, on this one. I mean, this was a curveball. I was expecting you guys to give me a follicular thyroid cancer with a little vascular invasion. What up with high-grade tumors? And we'll call this a kid. I guess it's 17. They're getting close to us. What are you thinking here?
Yeah, well, obviously this is an angioinvasive follicular carcinoma with higher grade features, which don't always necessarily translate into badness for kids.
Yeah.
And so we have to keep that in mind. So I think really right now is the discussion about completion thyroidectomy or not, with an intent to do postoperative staging to see if they would benefit from RAI. And I think this would push most people to probably recommend a completion.
Yeah, and Jonathan, you had talked a little bit about vascular invasion pushing you one way or the other. Think about it in this case for me.
Yeah, so this at least new to me entity of high grade follicular pattern tumors with papillary differentiation threw me a curveball the first time I saw it on a path report, and not really knowing what to do with the grading in a pediatric tumor, because it's not something I was used to seeing. There were a couple of papers that came out of a small community hospital in Manhattan that looked at this. I think Dr. Tuttle was one of the co-authors on those. And in general, they tend to have a much more favorable prognosis in children than they do in adults. So the mitotic rate in and of itself, absent necrosis, absent other invasive features, doesn't inherently raise the hairs on the back of my neck. At the same time, in that small population of children with high-grade features, there was a non-trivial rate of distant metastases again. So I think about 33%, 1 in 3 of those children with high mitotic rate did have lung metastases. And so I think I agree with Stephen here that this really does obligate a better more comprehensive postoperative staging than can be achieved in a patient with a lobectomy. So I think we're sort of compelled to pursue a completion thyroidectomy, and also recognizing that that disease may not be present or detectable initially, but this is a child who's got 50, 60 years of life ahead of them, and we want to be able to sensitively detect the distant metastases or the recurrence when that kid has moved across the street and as an adult. So I think, although we've moved away from the prophylactic approach to surveillance, this is a child or a young man who would warrant the more aggressive approach to facilitate the long-term follow-up.
That makes sense. Bill?
Yeah, this is fascinating. So these differentiated tumors with high-grade features. It's a new category, so we really don't know a lot about how they're going to behave. But I will say that in adults, it's important to correlate it with molecular. In adults, a majority of these are associated with very high-risk mutations such as TERT, P53, BRAF, ALK. But it seems like, in children, there's a little bit of data out there to suggest that these patients might do better. And in particular, this case, it's associated with a dicer mutation, which is not a high-risk molecular alteration. So that might portend something good despite the high-grade features.
Yeah, and I think Dr. Nikki Forfall saw a small series of 5 or 6 poorly differentiated kids. I think 5 of them were dicer 1. So this theme of dicer 1 in this small groups, but worth looking at. Dr. Wong, if we're going to really think about lobectomy or completion thyroidectomy, part of it is, as Jonathan said, for surveillance. The second's REI avidity. Any thoughts yet on whether these are going to be REI avid or not, or too early to know?
Too early to know. We do think that with poorly differentiated thyroid cancer, of course, it's kind of going down that spectrum towards non-iodine avid, not a good expression of the sodium iodine importer, and then now they're going to be FDG avid. But the definition of iodine avidity is based on a scan, right? So unless you do the scan, the pathology in itself will not directly inform you on whether it's going to be avid and whether radioiodine will have a role in this case. So
yeah, we're the same way. We're still trying to figure it out. We have definitely seen some cases of high grade, particularly the high grade differentiated folliculars and papillary that are RAI avid. We're trying to get our handle on what the number is and does it correlate with RAS or BRAF, but it's certainly not 0. So we're out there. All right, Andy, keep going for us. Where do we go with this young man?
All right. So I think we went over those. We can skip that slide. And then we've talked about this, and 2 points. One, these take hours to talk about with patients, so we're fortunate to actually have time in clinic to talk about it. And it's not, you just have to talk about what the options are. And germline dicer, it's another discussion, because if you have a lifelong risk of bilateral disease, even if you present with unilateral disease, you still have to talk to the patient. What's the risk and benefit if we remove half your thyroid, and then the burden of surveillance versus the burden of removing your whole thyroid. So every one of these steps in these indeterminate gray zones take an enormous amount of time, and some families are completely engaged, which is what we hope for, but they take longer. And the patients that seem less engaged, sometimes it's a little shorter, and then we all worry that they're not as engaged as we want them to be. But anyway, they underwent, after long discussion, completion thyroidectomy. And as predicted, there was nothing in the contralateral lobe. So it was mostly to pursue the next step to determine if there was distant metastasis. And that, of course, was another discussion about what should be the next step as far as how do you determine if there's distant metastasis. And if there isn't any now, what's the prediction 5 to 10 years from now? So we can go to the next slide.
Andy, just to pause there, you talked about the germline dicer. The other thing to think about is this is a 17-year-old in peak reproductive age who may have children of their own in the near future. Germline dicer can predispose infants to congenital tumors of the lung, particularly, and so that's something one would want to know prior to pregnancy so that appropriate surveillance can be offered to the infant at birth. And so I think there's an added urgency to at least offer counseling regarding germline testing in this patient.
Right.
And I think
go ahead, Mike.
I was going to say, I think your point's well taken. I've had patients, not 17s, but in their 20s, same scenario. We do a completion thyroidectomy and the thyroglobulin is essentially undetectable. And they opt not to do radioactive iodine, right? You could still, if it's undetectable, you could still have microscopic disease and you could still have an adjuvant therapy discussion. But I've had a few patients find that reassuring enough in their reproductive years not to do it. So I think while I would be leaning toward completion of radioactive iodine, that second decision point is seeing what that TG is after that after the completion thyroidectomy adds to the discussion.
Right. And the detection and surveillance for pleuropulmonary blastoma is critical in newborns, to Jonathan's point, because that is a tumor of Dicer 1 that, if you don't catch it early, progresses, undergoes sarcomatous change with high mortality. So absolutely part of the discussion. So next slide. So we're going to do something. That's why we went back to the OR after that long discussion. Our initial discussion was, of course, the usual approach, a diagnostic whole body scan. But that was another long discussion about, should we undergo exposure to radioactive iodine? It's amazingly low risk, even despite reassurance and no safety precautions for the I-123 diagnostic whole body scan. Back and forth, talking to radiology, nuclear medicine. We pursued to get an FTG PET after a negotiation, I think is the nicest description and probably most accurate. It really was a negotiation.
All right, and PET shows really nothing but
Yeah.
brown fat, I assume.
Right. So no distant metastasis. And we talked about it and said, if it's negative, we still want to do the diagnostic whole body scan. That was part of the negotiation. And so then we pursued the whole body scan and a stimulated TG.
Next slide.
Next slide. And that's the next slide. So there it is.
I'll jump in here. We got a TSH of 47 and a thyroglobulin was quite low, quite comprehensive surgery, 0.9. The iodine 123 shows these 3 spots in the neck, which is very typical of remnant thyroid tissue. The SPECT CT has really been the game changer since about 2005 because we can see exactly what this tissue is. And based on the appearance, this looks like thyroglossal duct remnant, which is an embryological common variant, as well as bilateral thyroid bed remnant, which is where the recurrent laryngeal nerves like to live, and the surgeons aren't going to be too aggressive in this area. So these are normal thyroid tissues, and the thyroglobulin will become undetectable once the patient is restarted on levothyroxine. So the decision not to give radioiodine just to get rid of normal thyroid tissue seems appropriate. I will just mention that on ultrasound follow-up, you just really want a diagnostic service which is quite experienced with following up remnant tissue and not getting overly concerned of there's some tissue in the thyroid bed that didn't get radioiodine. I would also caution that with a Ki-67 of 10%, even though everything looks good at this point after the surgery and radioiodine, just to not be overly enthusiastic that we're out of the woods, just because there is a chance that in the future we're going to have to redo these imagings based on what the thyroglobulin's doing. It just worries me a little bit with these high mitotic indices in diseases. We just don't have any imaging that can pick up microscopic disease at this early point.
All right, take us home, Andy. How'd this case end up?
So thankfully, the next discussion was actually relatively short, which, you know, we're happy the surgeon didn't leave much of a remnant because that makes things much, much easier. And we did not give radioactive iodine. But again, that was a discussion and not in 10 minutes. It was a relatively long discussion. So I think the next slide is the follow-up. Yep, we can skip that. Right. And then the problem we currently have is that the family, for various reasons, personal reasons, has not agreed to do germline Dicer 1 testing. So that leaves us in an unusual and somewhat challenging situation. But it's an ongoing discussion. So every time we see the family and, you know, involving genetic counselors and your cancer predisposition team, if the family is willing to see him, is an important part of this discussion. So they understand what the risk and benefit of pursuing or not pursuing germline testing is. But as of now, we haven't been able to get an agreement to pursue it.
And as you say, that's an ongoing discussion. I've had some of these that take 2 or 3 years before we actually get to germline, right? Think about how much she has thought through, the family has thought through in the time you've been doing that. So I think you're well said to sort of keep that door open. Well, we're not going to make it to case number 3 or 4. We will bring this panel back for sure. This was such great discussions. Thank you, Andy, for fantastic cases in pathology. Thank you, panel, for a wonderful discussion. And we'll wish everybody the best. Don't forget the Voices of Wisdom podcast. And we'll see everybody back in our next meeting. Thanks, team. Bye-bye.
Thank you, everybody.